So in this lectorial, we're going to discuss a few surgical topics that relate to kidney disease. We're primarily going to talk about renal tumours. There are lots of different types of renal tumours, and I don't really expect you to have an in-depth knowledge about all the various and complicated subtypes, but I've just picked a couple of topics for us to discuss. Firstly, we're going to talk briefly about renal tumours in children, and we're going to use Wilms tumour as the classic example. And then about tumours in adults, where we're going to talk about renal cell carcinoma. Urothelial carcinoma also involves the kidney, and we discussed that in the lectorial related to urothelium. So the pediatric renal tumour that I want you to know about is called nephroblastoma, or goes by the eponymous name of Wilms tumour. So nephroblastoma is one of the embryologic tumours that derive from the sort of primitive cells that differentiate into adult structures during embryologic life. And in the kidney, we have this embryologic material called nephrogenic blastema. And blastema is the primitive cellular element which forms the most of the epithelial and stromal elements of the kidney. So these are pediatric tumours, and very rarely they can be seen in adulthood. And they have a sort of peak incidence in the sort of 2 to 3 year age group. The classic presentation is as an abdominal mass, and this is often picked up by the parents when they're bathing the kids or changing their clothes. In the past, the only treatment was surgical, and the outlook for many of these children was pretty grim. However, now with aggressive chemotherapy, modern chemotherapeutic options have improved the survivability from these tumours to greater than 90%. So these tumours are often described as being triphasic. What do we mean by that? Here we've got this blastemal element. So these are the primitive embryologic cells that you'll see in the range of organs during embryogenesis. So normally the blastema matures and goes away by the time of birth. But in these Wilms tumours, this blastemal element persists, and some of the tumours contain only this expansile blastemal element. But blastema usually differentiates into epithelial elements, and so often in these tumours we'll see blastema and differentiation towards sort of tubular epithelium. And blastema also differentiates towards stroma that might form smooth or straightened muscle, for instance. And so classically these Wilms tumours are triphasic. They have blastema, they have the epithelial component, and they have the stromal component present as well. In adults, the kidney tumour par excellence is renal cell carcinoma. And these account for 2 to 3% of all malignancies. New Zealand is one of the high incidence countries, along with European countries, the US and Australia. And the incidence of these renal cancers has been increasing at an alarming rate over the last 20 years. This is probably not a real increase, but the detection is really a result of what we call VOMIT, which stands for Victim of Medical Imaging Technology. So what's happening is that patients are having CT scans, chest, abdomen, pelvis for a whole lot of other conditions, and so these small, almost incidental renal cell carcinomas are turning up on these scans. And I think this is responsible for the rapid rise in incidence. Kidneys, of course, though, these sort of saddlebag location in the retroperitoneum, which is really quite a silent area. So unless these tumours are detected incidentally by imaging, then often patients present with these tumours very late. By the time they've got to a large size, they may present with loin pain or hematuria, but many remain silent, and in fact the first presentation can be in up to a third of these tumours by metastatic disease, and then it's only by further investigation that the primary is revealed to be a parenchymal tumour of the kidney. Traditionally, the mainstay of treatment for these tumours has been surgical, trying to deal with the tumours before their metastases have developed, and there was really very little to offer patients by the time they had developed metastatic renal cell carcinoma. But in the last 10 years, there have been very significant advances in targeted therapies, particularly TKIs, tyrosine kinase inhibitors, which have shown really considerable success in survival improvement in people with metastatic renal cell carcinoma. So obviously the aim would be to detect these renal cancers at a low stage. But as I say, often in the silent location in the retroperitoneum, they've grown quite large, or they've invaded outside of the kidney or into surrounding structures such as the adjacent adrenal gland, for instance. One of the unique features of renal cancers is that they have a very high propensity to invade venous structures. And here we've got a renal vein you can see around the outside. And this is a big thrombus of a renal cancer present in that renal vein. So because they spread hematogenously, they often show up in the brain or as sort of cannonball-like lesions in the lung. And things like this can be, as I say, the first presentation, unfortunately, for a renal cell carcinoma. Our understanding of renal cell carcinoma has changed considerably over the years. When I was a medical student, we were taught that all renal cell carcinomas were the same, and there was really only one disease, and that disease we called renal cell carcinoma. And we kind of ignored a bit that the fact that there were different sort of morphologic appearances down the microscope. But our understanding of the chromosome changes and genetics in renal cancer has evolved, which has enabled us to separate out these tumours which we used to throw into just this one disease, renal cancer, and realize these are very different entities with different outlooks and which require different specific treatments. So the most common of the subtype is so-called clear cell renal cell carcinoma. And you can see here why it would be called clear cell cancer, because the cells are these large cells with very optically clear cytoplasm and these relatively small centrally placed nuclei. And these cells are clear in appearance because they contain lipid and glycogen, which is dissolved out in our tissue sectioning. But in the gross, you can see a very typical appearance here of a large renal cell, clear cell renal cell carcinoma, sort of replacing the upper pole here of the kidney. And this lipid, which is in these cells, stains this bright yellow color. So this is very typical for these clear cell renal cell carcinomas. Here's a very large one. Again, we've got the focal yellow areas, some pale areas. This is what we don't want to see. So this is a very large renal tumor. Here's the uninvolved kidney down the bottom. You can see it's growing outside of the renal capsule, invading the fat and invading the adrenal gland up here. Here's one of these clear cell renal cancers, again, yellow in appearance, and this time showing that propensity to invade into veins. And here's the renal vein, absolutely stuffed full of this sort of embolic sausage of clear cell renal cell carcinoma. And this can extend right into the vena cava, and in times it can even extend right up into the cardiac chambers. So we've come to understand that clear cell renal cell carcinoma has a specific genetic characteristic, and this is mutation in the von Hippel-Lindau gene on chromosome 3. So clear cell makes up about 3/4 of all the renal cell carcinomas, and the standard treatment is radical nephrectomy, removal of the kidney and adrenal and surrounding fat. But for small tumours, there's now a vogue to do sort of a renal conserving therapy and to do partial nephrectomies, just removing part of the kidney and the tumour. This is the most, as I say, the most common type of renal cancer, but it's also the most aggressive, unfortunately. And the 10-year survival figures are still not particularly flash for this type of tumour. As I say, we've come to recognise that there are different subtypes of renal cancer, and this is another common one, the sort of second most common, and this is called papillary renal cell carcinoma. And this has a very different genetic change to the clear cell renal cell carcinoma. So these are more solid in appearance, more discrete, they don't have that yellow appearance, and down the microscope they have this very distinct papillary features. Why do we bother recognising these subtypes? Because survival is much better with these sort of tumours than the clear cell ones. And some of the drugs that work for clear cell carcinoma are not very effective for papillary renal cancer. Here's another type, again with a different genetic, again this is called chromophobe. These often have a central scar. You can understand why for years we thought these were just part of clear cell or just renal cancer because they've got this clearing cytoplasm. But the nuclei are very different. They're sort of large, lobated, raisin-oid type features. And so again, it's important to recognize these as different from clear cell cancer because these have a much less aggressive behavior. Finally, in this, we should just make mention of the autosomal dominant polycystic disease, because these kidneys often come forward for removal at nephrectomy. So polycystic kidney disease is quite common in our community, and it can involve 1 or 2 per 1,000 births. And so this is a mutation in genes which code for a protein called polycystin. And patients who have this autosomal dominant abnormality develop cysts in various organs, liver, pancreas, but most commonly in the kidney. And these can involve any portion of the nephron, and they begin as small in pediatric life, and they just grow and grow throughout the life of the patient until they get to such a large size that they displace the normal renal parenchyma, and renal function becomes affected from mid-adulthood on. So often these patients present with silent chronic renal failure or hypertension, or because the kidneys are enlarged, these patients might have abdominal pains, or they sometimes form kidney stones as well. So this is a very common cause of end-stage renal disease, and it's a silent cause. Significantly, these patients also have association with barrier-aneurysms in the circle of Willis, and oftentimes these rupture in these patients can succumb from subarachnoid hemorrhage. So it's important to recognize that in these patients. As I say, they often come forward for nephrectomy, often bilateral nephrectomy, and a renal transplantation. So these is kidneys affected by polycystic kidney disease. You can see normal kidney here for size comparison. So these become very large, and the kidney is replaced by multiple cysts, and it's very hard to see any normal renal parenchyma left in these kidneys. So here's an autopsy brain. We've got all this clotted blood about the base of the brain. Here's the circle of Willis, and we can see here we've got a barrier-aneurysm that's ruptured. This patient's died from subarachnoid hemorrhage. Here's another more fresher example showing all this blood here in the subarachnoid space associated with ruptured Bréviaire aneurysms. So these patients often have this association, and it's important to recognise that. Thank you.